namaskar to all the viewers. Very warm welcome to today's special international faculty session. And this is our 350th webinar, and it's really a proud moment for all of us. Thank you for all your support, and I thank all the faculty, international, national, for supporting our programs. So today the topic is anticoagulation for RRT in the ICU, and it will be taken by Professor Thomas Rimmele, sir, and sir is now Professor of Anesthesia and Intensive Care Medicine, Head of Surgical and Medical ICU at the Nice Academic Hospital, Nice, France. So, sir was recently moved to this particular new hospital. Earlier, he was at Lyons. So, sir is actually taken a very nice lecture for us earlier, also around a year back, on dialysis as such, general concepts which many of you had attended, and it's up there on our YouTube channel also for those of you who may not know. And it has been doing very nicely. That has helped a lot of students and young doctors and young intensivists. So thank you, Professor Rimmele, sir, for sparing your time, and we look forward to the webinar. Over to you, sir.
Thank you very much, Tapesh, for this introduction. Thank you very much for inviting me again to this very cool initiative that I understand you launched a few years ago, Tapesh. So many lectures, so many webinars so far, and apparently a lot of people attending these webinars. So I think this is a very, very successful initiative. So congratulations. And thank you very much for having me with you today. So I think we have 1 hour. During 1 hour, I'm going to speak about anticoagulation for renal replacement therapy in the ICU. I will try to speak maybe 45, 50 minutes, and then I will be able to answer questions if you have on the chat, if this is how you do usually. But yes, I am with you for 1 hour. So these are my conflicts of interest. I work with the different companies in the field of renal replacement therapy. And this is the outline I'm going to follow. Actually, during most of this webinar, I'm going to talk about CRRT, continuous renal replacement therapy, but I will save a little bit of time at the end of the webinar to talk about intermittent hemodialysis, because this is also very important. And I really believe that it's important in the ICU to use both techniques. When the patient is very sick, you have CRRT, of course, when the patient has shock at the beginning. And then when the patient gets better, I think it's a good way to switch from CRRT to intermittent hemodialysis. And in France, actually, I don't know in India, but in France, you have 75 or 80% of the ICUs in which you have both modalities, CRRT and intermittent hemodialysis. And this is how we do usually when the patient is very sick, CRRT, and then yes, we go for intermittent hemodialysis. Sorry, I'm a little bit sick also, but I will try to speak for 1 hour. So this is a clinical situation. You are the intensivist in charge of the ICU, your ICU. You have a 50-year-old patient with multiple organ failure syndrome due to septic shock from pneumonia. Okay. You started 8 hours ago, CVVH, and you do 100% post-dilution. That's your protocol, let's say. And you provide anticoagulation with unfractionated heparin with an APTT of 1.2, the normal value. Then a nurse calls you because the TMP, the transmembrane pressure, is continuously rising, and there's an alarm on the machine. So you arrive, and then you look at the settings, the prescription of the CRRT, of the CVVH session. The blood flow rate is 120 ml per minute. The ultrafiltration flow rate is 2,500 ml per hour. And at this time, since the patient is in shock, you did not provide any net ultrafiltration. It's 0. Okay. So my question for you here, and I don't need I don't want you to respond to immediately, but to think, what do you do at this time? You have a rise of the TMP. The patient is CVVH with unfractionated heparin. The blood flow is 120. The ultrafiltration flow is 2,500. And my question for you is, what do you do? But before you answer, or before I give the answer, after you think, I would like to talk first about the three options that we have in 2026 for anticoagulation for CRRT. Of course, citrate. And I know that in India, citrate is not so much used. And this has to change, for sure. For sure, in India, like everywhere else in the world, you need to provide citrate to as many patients as possible, because these are the recommendations. We're going to talk also about heparin and about no anticoagulation. So citrate. First question. What's the main difference between citrate and heparin for circuit anticoagulation? So, of course, that's an easy question. Citrate, you provide anticoagulation for the circuit only. Only the circuit is anticoagulated. It's a regional anticoagulation, as opposed to heparin. When you give heparin to a patient in CRRT, you provide anticoagulation for the circuit and for the patient also. What is the mechanism of action of citrate anticoagulation? Citrate binds the calcium, right? And the calcium, as you can see here, is present at all the different steps of the coagulation cascade. And this creates, the calcium citrate complexes. The calcium citrate complexes, they are like this. You have the calcium that binds to carboxylate radical, and you have still one carboxylate free here. And this free carboxylate provides an anionic charge, which means a mild acidic effect. Okay? So when you have calcium citrate complexes that leads to metabolic acidosis. It's very important to remember this. When you have a lot of calcium citrate complexes, you tend to have metabolic acidosis. Remember this, and this is due to this free carboxylate radical. And very important slide also. When you give heparin in your patient, if you give a little bit of heparin, you anticoagulate a little bit. If you give a lot of heparin, you anticoagulate a lot. With citrate, it does not work like this. With citrate, if you give a little bit of citrate because you are scared maybe of the complications, you are scared of the metabolic complications, that will not anticoagulate a little bit. That's actually not a good thing to do. With citrate, you definitely need to do the citrate anticoagulation correctly and to give the correct dose to reach a calcium level in the circuit of 0.3, 0.4, between 0.3 and 0.4 millimole per liter. It's an on-off effect, okay? So with citrate, please do not just do a little bit of citrate because you think it's going to be, it's to avoid metabolic complications. actually you will take the risks of citrate without the benefit, because if you provide a little bit of citrate, you are not going to anticoagulate your patient. Okay? So that's an on-off effect, and it's very important to remember this when you provide citrate anticoagulation. Another point which is very important to understand with citrate anticoagulation. These calcium citrate complexins, once they are made, they are in the circuit. What happened? What happened to them? Well, so I said that you give citrate in order to reach 0.3 millimole per liter of calcium in the circuit. At that level of calcium, there is no coagulation possible. That's why it's a very good anticoagulation. Because coagulation is not possible at that level of calcium. When you have 0.3 millimole per liter of calcium, that means your concentration of citrate in the circuit is around 4 millimole per liter. On the daily clinical practice, the labs in the world, they don't measure the citrate concentration. But if you have 0.3, that means usually your concentration of citrate is around 4 millimole per liter. So it's an indirect information telling you that your citrate concentration is around 4 millimole per liter. So at the beginning of the circuit, you create your calcium citrate complexes. Okay, I will show you here. You can see the slide. At the beginning, you create your calcium citrate complexes, and here in the circuit, you have your calcium citrate complexes, and you have 0.3 millimole per liter of calcium, alpha ionized calcium. At that level, you have no anticoagulation possible. So it's very good anticoagulation. And then these arrive in the membrane. In the dialysate, here it's CVVHD. Okay. In the dialysate, you do not have any calcium. So you are going to lose a little bit of calcium. A little bit of ionized calcium is going to be dialysate in the dialysate, okay? And also you are going to lose in the dialysate, in the effluent, you are going to lose calcium citrate complexes. Actually, approximately 50% of the calcium citrate complexes are going to be removed in the dialysate. And then you still have here the return line. And at the end of the circuit, you provide calcium to re-increase your calcium level in the patient. What you have to remember is that the calcium you give here at the end is only here to replace the calcium that has been lost in the dialysate. Not a lot of people understand this. So I would like you to understand that the calcium that we give at the end of the circuit is here only to replace the calcium that has been lost in the dialysate. Okay? And that's actually why the pump of calcium here directly works with the dialysate pump. They work together, the pumps. If I increase, for some reasons, if I increase my dialysate pump, I will remove more calcium citrate complexes in the effluent. Automatically, the calcium pump is increased by the machine. You don't have to do anything. Okay? That's very important. And so that's the outcome of the calcium citrate complexes. Some 50% are removed in the dialysate or in the ultrafiltrate if you provide CVVH. What about the other 50%? The other 50% are the ones who are going back to the patient. Okay? And what's going on? They arrive in the patient, and in the patient, there is metabolization from the muscle, from the liver, and from the kidney. Where exactly? In the mitochondria, in the Krebs cycle. The name of the Krebs cycle is also the citrate cycle. The other name of the Krebs cycle is the citrate cycle. Okay, that's biochemistry. So your calcium citrate complexes, they are metabolized in the mitochondria, in the citrate cycle. Okay? And then at that moment, you get back your calcium that you gave at the beginning. That's when everything is okay. Okay? Liver, muscle, kidney cortex. Here I noticed that there is a sodium release at that moment because this at the beginning of the circuit here, that what you give is sorry, what you give here, as you can see, this is trisodic citrate. Trisodic citrate. So you give a lot, you use a lot of sodium. So when these calcium citrate complexes are metabolized, there is a release of this sodium. And so you can get hypernatremia, you can get an increase of your strong iron difference, leading to metabolic alkalosis. But I will come back on that later. Okay, so I think at this time, I have explained how citrate anticoagulation works. Another important point is the dialysis catheter anticoagulated in case of citrate anticoagulation. Well, look at this picture from a patient. Again, this is your extracorporeal circuit. The citrate arrives at the beginning of the circuit, and the calcium at the end of the circuit. It's a regional anticoagulation, right? Only the circuit is anticoagulated. What about your catheter here? Is it anticoagulated? No, it's not. That's why this is very important also to understand that when you run a session in your ICU with citrate anticoagulation, you have to manage correctly the dialysis catheters because they are not anticoagulated. If you run heparin, and if you do not have a good dialysis catheter in your unit, then it might be okay just because there is a little bit of anticoagulation inside the catheter due to heparin. But with citrate, no. With citrate, there is no anticoagulation inside the catheter. So you have to manage correctly. You have to have the good dialysis catheter in your unit, the right length, the right size, and we'll come back on that a little bit later also. Okay? So usually when you start citrate in your unit, and I understand that in India, a lot of ICUs need to start with citrate. So if you have good catheter, it will work. And if I come back to you in 1 or 2 years and I see you and you are going to tell me, oh yeah, we started citrate anticoagulation in our unit and we are very, very happy. The nurses are very happy. Everyone is very happy because now the sessions, they last 72 hours. We are very happy with this. Sometimes I hear, oh, with citrate anticoagulation, you promise us very good things with citrate anticoagulation, but actually it's not so good. We still have a lot of problems. We still have a lot of clots in our circuits. Usually when people tell me this, it's because they don't have good dialysis catheter in the unit. Okay? So I think this point is crucial. If you want to manage correctly citrate anticoagulation in your unit, you have to have good dialysis catheter. So what are the 3 main advantages of citrate anticoagulation over heparin? And this is why the KDIGO guidelines, the international recommendations, now recommend citrate anticoagulation as a first anticoagulation strategy in front of heparin in almost all the patients, and I will come back on that. So the three main advantages. All the studies, the small, the big, the old, the recent ones, from all the different countries, the monocentric studies, the multicentric studies, they all found the same result. I think it's very rare in the ICU that in intensive care medicine that we have all the studies finding the same thing. In many topics in the ICU, we have debates, pros and cons, But with citrate anticoagulation, there's no debate because all the studies, all the randomized controlled trials found the same result. Citrate increases the filter lifespan by a factor of 2 to 3 to 4, 3 times more. 3 times more. You see, it's not a little bit of increase. You double, you 3 times. If you had a filter lifespan with heparin in your unit of, I don't know, 15 hours on average, 20 hours on average, then with citrate, you can reach 3 days. 3 days with nothing to do. So as you can imagine, the nurses, when they try citrate, they never want to come back to heparin because, the patient is very stable for 3 days. There is no problem and it's very convenient. Again, monocentric studies, multicentric studies found the same thing. And why? I don't have to say anything. Just look at the pictures. Okay? That's inside the membrane with heparin, and that's inside the membrane with citrate. I think there's nothing to say. Everybody can understand why with citrate the sessions last longer. Of course, there is a decrease of the bleeding risk. Why I explained that it's a regional anticoagulation. You anticoagulate only the circuit. The patient is not anticoagulated. So, of course, the bleeding risk from this meta-analysis, the bleeding risk is less important with citrate, favors citrate. That's an advantage of citrate. You decrease your risk of bleeding complications. With heparin, you can have bleeding complications. I think everyone experienced in the past, you provide renal replacement therapy for a patient, you give anticoagulation with heparin, and you have a bleeding complication because of the anticoagulation. This doesn't happen with citrate. And another advantage, and this is not a small one, since you have less problems, less clotting in the circuit, less stops because of a circuit failure, less stops because your catheter has a problem, a clotting inside, because it's a better anticoagulation. Then your administered dose, dialysis dose, is going to be optimized. I hope you all know this slide. This is very important. In renal replacement therapy, if I want to reach the dose of effluent of 25 ml per kilo per hour of effluent, that's my dose that I want from the KDIGO guidelines, from the international recommendation based on different studies published in the New England Journal of Medicine. We want this dose. To reach this dose, I need to prescribe more. I need to prescribe 35 ml per kilo per hour because I am going to lose a little bit of dose during the nursing time, during the time when the nurses are going to change the bags. If your patient has to go to surgery, is not going to surgery with this machine, right? When the patient you want to CT scan, when there is thrombosis, when you have a catheter problem, you stop the machine, right? So then you lose a little bit of dose. So that's why if I want to get an administered dose, a delivered dose of 25 ml per kilo per hour, I need to prescribe 35. So before the word dose, I used to tell my fellows, when you talk about the dose, please, before you precise if you are talking about the administered dose or the prescribed dose. When you prescribe your renal replacement therapy, you prescribe 35 ml per kilo per hour. And then you hope you will reach 25 ml per kilo per hour. Okay? So you understand that if you provide citrate, if you use citrate, you will have less problems here. Less problems, less clotting, less change of your catheter, less thrombosis, because it's a better anticoagulant. So you can optimize your dialysis dose. Now in my center, 100%, almost 98, 99% of the CRRT session, we provide citrate anticoagulation. And the patients, I can tell you, are sick. And they are really sick. And, a lot of people would say that they are contraindicated. But no, they are not. I will come back on that. But what I've seen is we do not have any problem. Now the session is 72 hours. And so we optimize the delivery dose, I think. And now, if you have a very active, a team which is very reactive, then in centers with a lot of experience with citrate, you can prescribe 30 ml per kilo per hour and not 35, because your nurses are very active, reactive in case of a problem. Okay? So because of all these advantages, the KDIGO guidelines in 2012, more than 13 years ago, 14, almost 15 years ago, told the entire planet that for renal replacement therapy, now the first anticoagulation should be citrate in all patients, except in patients with contraindication. But at that time, in 2012, we didn't know what the contraindications are. It's not even written in the KDIGO guidelines. It's not even written liver insufficiency, shock, intoxication. It's not even written. It just said patients who do not have contraindication. So the good news is that in 2026, we will have an update of the KDIGO guidelines. There will be the new KDIGO guidelines in 2026, probably at the end of the year. And I'm sure the experts are going to write to explain, to give more information about the contraindications. But the contraindications, we know them. Classic. And if I ask you, you will tell me, oh, the contraindication is liver insufficiency, because we said that the calcium citrate complexes, they are metabolized in the liver. Okay. But are you talking about absolute contraindication or relative contraindication? Liver insufficiency, are we talking about a patient with a factor 5, a 5 factor of 55%, or a patient with a 5 factor of 5%? Shock. Shock and contraindication. That's a problem because we have a lot. the ICU is supposed to receive patients with shock. So if shock is a contraindication, that's a problem. But shock, are we talking about a patient with a lactate of 4 millimole per liter or 20 millimole per liter of lactate? Intoxications, what intoxications? You see, it's very, very relative actually. And again, in expert centers, 98, 99% of the CRT stations, they are run with citrate. Because this is now what should be done in 2026 from the KDIGO guidelines, from the recommendations. And again, I'm telling you that in India, it should be like this. Definitely. You should start in your unit citrate anticoagulation. Really, it's mandatory. You have no choice. Okay? So that's why I really encourage all the good people from India, for the good doctors from India, to really start a citrate protocol in your unit. It's time now, 2026. We have information. It's doable. It's doable. And it's not more expensive than heparin. Not true. Untrue. A lot of people tried to look at the cost. And when you look at the cost, it's very difficult in the ICU because, of course, you have to take everything into account. If you look at, of course, just the lab, the cost of the lab, the surveillance, the ionized calcium you have to monitor and everything. That's a little bit of cost. This is costly, of course. But look what you can save. You are going to save money from the different circuits. If you use one circuit instead of 3 or 4, you save a lot of money. And but even that, your patient, he wants a dose of renal replacement therapy. If you want to reach the dose, you will reach the dose with citrate anticoagulation. With heparin, if you have a lot of problems, you may have you will not dialyze enough your patient. So really, there are green lights for citrate for everything. Okay, so I strongly encourage you to go to citrate. So you start like that. An example. I don't know if we will not go to all the protocols, of course, because I don't know if you use CVVHD, CVVHDF, CVVH in India. Probably a little bit of all. You prescribe more. You prescribe your dose of the prescribed dose, 30 to 35 ml per kilo per hour, and then you have your blood flow. And then you target concentration of citrate, 4 millimole per liter. And then you target concentration of calcium, 1.7. Natural filtration, the weight loss, what you want to remove from your patient, is at the end. I'm not to go into all the details, but this is how it works. And okay, so that's a machine, that's the machine from my unit. You see, you have the blood flow, the dilute flow rate, the effluent, the citrate flow, and the calcium flow. And the flow is here. That's the target concentration. Again, the target concentration of citrate in the circuit and the target concentration of calcium at the end of the circuit. Okay? And you have every 6 hours, you check the calcium level in the circuit. That's inside the circuit. You check the calcium level, and then you increase or you decrease your citrate dose, and you do this on the machine, and then you measure also your calcium level in the patient, and then you can adapt the flow of calcium at the end of the circuit to correct the the calcium level in the patient this time. So with heparin, you have the hemorrhagic complications. With citrate, you have the metabolic complications. Two metabolic complications you have to be aware. So with citrate, you have to be familiar with the Stewart approach. The strong ion difference, cations and anions. And then you can get all these complications. Metabolic alkalosis, metabolic acidosis. So I will start with what is the most dangerous, the only dangerous complication with citrate is the accumulation of the calcium citrate complexes. If you have accumulation, I told you before that the isolated carboxylate gives a little bit of acidosis, right? So if you have an accumulation of calcium citrate complexes, you will have metabolic acidosis. Okay, so when you have metabolic alkalosis, this is not accumulation. This is the other complication, which is not dangerous. Okay? So metabolic acidosis with increased ion gap, that's one of the biochemistry lab signs that you can have. But you have ionized hypocalcemia. And that's why it's dangerous, because if it decreases too much, you can face cardiac complications because of this low calcium in the patient. Calcium substitution requirements continue increasing. And another good sign is your total calcium over ionized calcium is increasing. These are the signs that tells you that maybe the patient is having an accumulation of the calcium citrate complexes. You see, the total calcium you measure in the lab, we measure the ionized calcium, the calcium bound to the albumin, and the calcium from the calcium citrate complexes. So if your total calcium over ionized calcium is increasing, that means that you are facing accumulation of your calcium citrate complexes. I strongly recommend this publication that we wrote with two good friends a little bit of few years ago that explains these complications. And you have to read it carefully in a quiet environment, because once you understand this, you will feel very safe to use citrate anticoagulation in your unit. So really read this publication, and then you will feel very safe using citrate. Again, so you have calcium citrate complexes. If the Krebs cycle doesn't work, this is when your calcium citrate complexes are not metabolized. So they are accumulating. So that is what we said, metabolic acidosis, anion gap increased. Okay. But if your Krebs cycle works, there will be no accumulation. There will be metabolization of your calcium citrate complexes. And that, I told you before, you have a release of your sodium, and that increases your strong ion difference. And that's why you may have hypernatremia and metabolic alkalosis. So if you have metabolic alkalosis, it's not dangerous. This will not kill your patient. You do not have hypocalcemia in your patient, so it's not dangerous. So what you have to do in this situation, you will have to, it's the same management for both complications. That's what is simple. If you decrease a little bit your blood flow, you will decrease the formation of your calcium citrate complexes, right? And if you increase your effluent flow rate, you will increase the removal of your calcium citrate complexes, which is also what you want. Okay? So that's the management of the complications. So how to limit the risk? you want to provide as little citrate as possible. And so remember here that what I told you before, the pumps, they work together. That's why it's safe now. We know that citrate is a very good anticoagulant for many years. Actually, we put a little bit of citrate in the blood products, right? Because we know it's a good anticoagulant. But we didn't use it for extracorporeal circuit before because in the past, the companies were not able to provide machines with pumps working together. Here, in the new machines, the citrate pump works with the blood pump, and the calcium pump works with the diazide pump. So you don't have to worry too much. If you increase your diazide flow rate, I told you that will increase automatically my calcium administration. If I decrease my blood flow rate from 150 ml per minute to 120 ml per minute, automatically my citrate pump is going to decrease here. My citrate flow. So here you still have 4 ml, millimole per liter, but my citrate flow is automatically going to be decreased. That's why it's easy, okay? The decrease of your blood flow, you can do it easily with diffusion, right? In CVVHD. I don't know in India, but I think maybe you do more convection, CVVH or CVHDF. Be careful with CVVH. You cannot decrease too much your blood flow, right? Because what's going to happen if you decrease too much your blood flow? You will increase your filtration fraction. You will increase your hemoconcentration inside the filter. These are the formula of the filtration fraction that you have to know. In case of 100% post-dilution or in case of pre-post dilution. Target is 20 to 25%. That's true that this is the target with heparin. With citrate, you can increase a little bit your filtration fraction. You can tolerate a little bit more of filtration fraction. Maybe 30% should be okay with citrate. With CVVHD, you can usually, I told you, I'm going to go quick on that slide, with citrate in many patients. In all my patients in my ICU, with CVVHD, you can decrease your blood flow. There is no problem. There is no filtration fraction issue. So if I give a little bit of flow, little bit of blood flow, there will be a little bit of citrate administration. You are telling me that in case of liver insufficiency, you do no anticoagulation because you are afraid of citrate accumulation. Not a good practice because now we have a lot of evidence, a lot of studies have shown that in liver insufficiency, it is safe. It is safe because some of the cells of the liver are still working. The mitochondria still working. And so in many studies now, they show that unless you have a very, very, very severe liver insufficiency, if you have a mild liver insufficiency, there will be no accumulation. So now liver insufficiency is not a strong contraindication for citrate anticoagulation. I think this is very important to understand this. When I have a patient with liver insufficiency, I do citrate anticoagulation and I don't have any problems. Of course, you are not going to start your first patients with citrate in a patient with liver insufficiency. But with the experience that we'll gain, then you will realize very quickly that it's not so much a problem. That's what the study says, no accumulation. There is only one situation that scares me a little bit. You know what it is? It is when the lactate increases in my patient. When lactate increases in my patient, it means that I don't do the right thing. And that means my Krebs cycle is not working very well, right? So that's exactly this study. Look, in black, this is the patients who had accumulation. In white, the ones who did not have accumulation. Even when you start with a low lactate, but you don't do well, you don't give the right antibiotics, you don't send the patients to the operating room if he needs to have surgery, then your lactate increases. And then there is accumulation. Same, I start admission, ICU admission, lactate is high, but you are a good intensivist, you do everything well. Lactate decreased in black, in white here, no accumulation. Lactate stays high, accumulation. So the kinetics of lactate, I think, is a good predictor of citrate accumulation. Remember this. I think it's a good predictor. Okay, for citrate anticoagulation, it's one of the biggest improvements in the ICU during the last 30 years. It's being more and more used in the world. In 2026, it's mandatory that you need to manipulate citrate anticoagulation in your unit, more and more in India. It's not more expensive. This is not true. Use citrate anticoagulation. And this is what the recommendations, it's been recommended for, we said, 15 years. So you follow the recommendations for the lungs, for the heart, for everything. For your renal replacement therapy machine, we also need to follow the recommendations and to provide citrate anticoagulation as the first line of anticoagulation. Okay, you don't want to do it because you have good reasons. Let's imagine, yes, my lactate is increasing, Thomas, so I don't want to use citrate. I'm a beginner with citrate anticoagulation. I'm scared. I would like to use heparin. Okay, fair enough. Let's provide heparin. Heparin, it's a historic anticoagulation strategy. Multiple advantages. It's easy surveillance. It's antagonizable by protamine. I'm talking here about unfractionated heparin. And it's true that it's low cost. But the major drawbacks, you anticoagulate the circuit, but also the body, right? And anticoagulation in the body means bleeding, or increased risk of bleeding, okay? And sometimes in the ICU, in the surgical ICUs, sorry, but it's bleeding, right? So it's a problem. That's the protocol in France. Okay, I'm giving it to you. There are different protocols, but that's how we provide. But again, it's been many, I don't do this anymore. We don't do heparin anymore, unless very rare situation. But that's the protocol. If I have to do a heparin in a patient, I would do like this. I would rinse my circuit with 5,000 units per liter. I would give a bolus of heparin, pre-filter, 30 units per kilo. And then I would use a continuous administration of 7 units per kilo per hour. And I don't know in India if you use APTT or if you use ACT for the monitoring or activity anti-10A. But then you monitor your level of anticoagulation. But then with this, my filter lifespan will be 1 day, I think, between 1 and 25 hours, something like this, 30 hours, if I'm good. Okay? The French guideline, the APTT target is 1.5 times the normal value. Okay, my patient is also bleeding. No citrate, no bleeding, no citrate, no heparin. then I'm going to use no anticoagulation in case of hemorrhagic risk and contraindication to citrate. Okay. Frequent or not? Actually, yes. Approximately 25% of the renal replacement therapy prescriptions in the world, no anticoagulation. I think it's too much, really, because usually it's not good. The blood, the blood cells, platelets, the white blood cells, the red blood cells, they are happy when they are in contact of what? Of the endothelium. If you take the cells out of the endothelium contact, like with plastic in an extracorporeal circuit, in a plastic contact, they are activate, coagulation activation. And so I think I really don't like not to give anticoagulation in a patient. But sometimes I have no choice. And then what I would like to say is that no anticoagulation does not mean nothing. First, no anticoagulation means you need to manage correctly your catheter. You cannot have a not good catheter, right? So you need to know where to put the catheter, right jugular vein first, left jugular vein second, femoral vein second, left jugular vein. You have to follow the KDIGO guidelines regarding the management of the catheter, right? You have the good to know which design, the Rimmele design, this one. You have to use the tip of the catheter like this to limit recirculation. The diameter, the length depend on the site of insertion. You have to be good with catheter. Of course, there is no anticoagulation. You cannot make any mistake with your catheter. Specific membrane, like pre-heparinized membranes. I don't think we have strong data in favor of pre-heparinized membrane. So IL-69ST, I know this membrane very well because it was made in the beginning in Lyon, where I was living before. And this membrane, there is a little bit of pre-heparinization. But the efficacy, the clinical efficacy, the clinical effect is very, very limited. Or I should even say not demonstrated. So I'm very, very cautious with pre-heparinized membrane. What is very important in your ICU is to manage anticoagulation as a team, the doctor and the nurse together. That's how you are effective. That in one center in France, they have new nurses, they train them, and then poof, after the training, the downtimes, when there are problems, decrease very much. So I strongly believe, and I hope this is already the case in your unit, that you have a small group. Now in France, almost on all the ICUs, we have a group of people with nurses, with doctors, together, a group managing the protocols, managing what the orders of the new products, managing the training of the new people arriving in the ICU to be good with renal replacement therapy. So if you don't have a group like this, a dialysis group in your unit, I encourage you to create in your unit a group of people with doctors and nurses taking care of the renal replacement therapy, education of your colleagues, the protocols. Okay, that's very important. When you do this, you decrease your downtimes. If you do not use anticoagulation, CVVH, we know that CVVH is more efficient than CVH because you do not have hemoconcentration inside the membrane. So it's already demonstrated that with CVVH, you will increase your filter lifespan. In CVVH, if you use CVVH in your unit in India, please calculate the filtration fraction when you make the prescription. It's mandatory. Calculate the filtration fraction. And if you do not use anticoagulation, you will please use a low filtration fraction, of course, and increase pre-dilution. So no anticoagulation, good vascular access, significant blood flow because, of course, if it circulates fast, there will be less clots. Diffusion better than convection, CVVH pre-dilution, absorption of heparin with hemofilter, although not pro evidence, and a teamwork. That's for no anticoagulation. So what do you think about this case? You have this patient, you provide heparin 1.2. That's true that it's a little bit low. I told you French guidelines, it's more 1.5. Okay. But you have your TMP rising. But look here, 1 in 20, 2,500. Did you calculate the filtration fraction? Filtration, well, I don't have time to go back on clotting and clogging now, but filtration fraction here is 0.35. With heparin, this is too high. The message here is that there is a common mistake in renal replacement therapy. Sometimes when you have this TMP increase, you believe, oh, there is not enough anticoagulation. Not enough anticoagulation. But this is because people did not calculate, did not pay attention to the filtration fraction. Here, filtration fraction was too high. That's why there was coagulation. Okay? Just a few slides, like 5 slides on intermittent hemodialysis. Intermittent hemodialysis, it's good because it avoids the risk associated with continuous anticoagulation. If you run an intermittent hemodialysis for 3 hours in your unit, you can do it with no anticoagulation. It's not going to clot because you are going to, it's not small time, small duration. It should be okay. That's a good thing when you have a bleeding risk important. That's how we can do if you run with unfractionated heparin, low cost, short half-life, people they know well how to manage. Again, APTT or anti-10A or ACT, and it's antagonizable by protamine. That's the protocol we had in the unit before. But now we have the low molecular weight heparins. Low molecular weight heparins, they are more recent. And now this is how usually anticoagulation is given in intermittent hemodialysis. Because these low molecular weight heparins, they are easy to administer. There is no continuous infusion, no monitoring, lower incidence of heparin-induced thrombocytopenia, which is something quite important, and less hemorrhagic complication. Okay, so I think it's a good thing to run an IHD session with low molecular weight heparin. So that's the conclusion before the question. So if you want to provide to a patient a continuous, safe, and efficient CRRT session, anticoagulation is very important, and I insisted very much on citrate anticoagulation. I hope you all understood. But remember also one last thing. Anticoagulation is not all. You cannot be good in anticoagulation and not good in the catheter, the dose, the modality, the filter. In renal replacement therapy, if you want to be good and provide a good session, you have to masterize all the aspects. Anticoagulation, catheter, dose, modality, all are very important. Thank you very much for your attention, and I'm okay to answer any question. Thank you.
Thank you, Professor Rimmele, sir, for a wonderful talk. Very nicely explained. Really grateful for that. So I request the audience, if they have any questions, please type in the chat box. So, sir, meanwhile, I can just put up a few points. So, sir, you mentioned that excess of citrate leads to classically metabolic alkalosis, so that is well recognized also. But sometimes we get acidosis also. So, can you tell us about the acidosis that we can get with citrate excess?
With citrate, you mean metabolic acidosis?
Yes, sir. So, how do you get that, sir?
So when you have metabolic acidosis, the first thing to do is what? What you learn at school is you have to calculate your ion gap. Is it a metabolic acidosis with increased ion gap or normal ion gap? Because then you can differentiate, right? Because in the ICU, you may have different reasons to have metabolic acidosis. And it's not because you have citrate anticoagulation, you can have metabolic acidosis due to something else. Okay? So if you have metabolic acidosis, it doesn't mean, it doesn't confirm at 100% that it's accumulation of the calcium citrate complexes. Then you have to look all the other parameters from the lab. The total calcium over ionized calcium. If it's increasing, then I'm more confident that yes, okay, maybe this is accumulation. But if my ratio remains low, I can say that my metabolic acidosis is due to something else. If I do not have hypocalcemia in my patient, I can confirm this is not accumulation. My metabolic acidosis is due to something else. Okay? So yes, in accumulation, there is metabolic acidosis, but all the metabolic acidosis are not due to accumulation. Okay? So that's why medicine is not so simple, but it's important to look and monitor the ionized calcium. The only risk of accumulation is the hypocalcemia. The patient, they will not die because of metabolic acidosis. They will die because of hypocalcemia. So monitor closely your calcium level in your patient.
Thank you, sir. So the acidosis that you get is classically increased ion gap or normal ion gap or both you can get.
This metabolic acidosis with, in case of citrate accumulation, calcium citrate accumulation, there is an increase of the anion gap, and there is an increase of the strong ion gap, depending if you do Anderson-Hasselbalch or Stewart approach. Both are increased. The anion gap is increased, and the strong ion gap is also increased.
Thank you, sir. So then you mentioned that citrate can now be used in liver failure patients or cirrhosis patients. So, but there are patients where you may not be able to use it. So in acute liver failure or in cirrhosis, advanced cirrhosis, which patients we can use and which we cannot use? What parameters can we use to decide?
Okay, Tapesh, this is a very good question. And the answer is different according to who I'm speaking to. If I'm speaking to a team from an ICU, they are, they have been using citrate for 2-3 years already. They know the concept, they know the machine, they know the protocol. Then I will tell them, okay, just do it in all the patients. And the only contraindication will be like an increase of your lactate. That's what is dangerous, because the increase of the lactate means that your Krebs cycle does not work. But if I am talking to beginners, okay, you never did citrate before, you did heparin before, then I will tell you, okay, look, you are going to start with easy patient, easy. Like, there is acute kidney injury, but the patient doesn't have any lactate increase, doesn't have any liver insufficiency, doesn't have any other big issues, right? Then you can do citrate. And then you will start to use your protocol, use your machine, and then you will become more and more experienced. And then I will tell you, okay, Tapesh, now in your unit, you can go with liver failure. You can start with citrate because it's demonstrated in the literature in many papers that it is safe. Okay, so don't start with these patients, of course. But as soon as you get a little bit of experience, you can provide citrate anticoagulation in liver patients.
Yeah.
Okay,
Thank
and
you, sir.
again, you monitor every 6 hours. Every 6 hours, you make the monitoring, and you see your calcium level. Okay, and as soon as it's okay, there's no problem. You just check, and check. You do the surveillance.
Yeah. Thank you, sir. So then, any role for prostacyclin in today's ICUs? Prostacyclin as anticoagulation.
This I don't. I'm sorry, but I do not have experience with prostacyclin.
Right, sir.
This,
Thank you, sir. Sir,
do you have in India? This is what you do
no,
in
no,
India?
no, nothing, sir. But it is just mentioned in the literature that it can be used, and people use it, especially in liver failure. They do use it. I had listened to one lecture from London, and they were using it, sir.
Yeah, but I think you can always find people using very strange things, and it's like heparin protamine, the heparin protamine, like regional anticoagulation with heparin protamine. That's also, I've never done it. I've never done it. And I know it's also dangerous to do this because you can face different problems. It's not easy. Now, what we have in 2026 as a tool for anticoagulation worldwide,
Right,
heparin, citrate, low anticoagulation, enough. You can you can face all the situations like this.
yeah. Thank you, sir.
And to any other types, I don't think you will have enough studies, enough patients to get good anticoagulation protocols like this.
Right, sir. Thank you, sir. So, final one point, sir, about the regime for citrate, giving citrate. So, regime. So, what? How do you best? What is the best dosing and flow rate, etc., for giving citrate?
So the dose,
Yeah. So, what is the best dose? Because different ICUs tend to kind of use different dosing regimens and all that, sir. So, is there a best way to give citrate dosing, etc.?
you mean the dosing of what? Dosing
Of
of
citrates, citrate use. When you use citrate, what is the best way to give citrate? The dose, the flow rate, etc., and all these things, sir.
well, there's no there. There are so many different protocols because it depends of the modality. It's not you have different protocols in CVVH. You have different protocols in CVVHD, and you have different protocol in CVVHDF. All are good. There's no problem. Then you have different types of citrate. You have concentrated citrate, the trisodic citrate, and you have diluted citrate, 18,0 citrate from Ventive, concentrated citrate with Fresenius. So you have different types of citrate. Then you have different types of substitution fluid. All are different. So you can make like maybe 20, 25 different protocols, and they are all good. It depends of what you have in your unit. And I'm sure, I don't know how many people are listening now, but from many ICUs, I'm sure the devices, the protocols, the what the people they know is different. CVH, CVVHDF, CVVHD, different. So the protocols have to be adapted to this. Okay? Tapesh?